Welcome to the Neurostimulation Podcast. I'm Michael Passmore, Clinical Associate Professor in the Department of Psychiatry at the University of British Columbia in Vancouver, Canada. The Neurostimulation Podcast is all about bringing cutting-edge neuroscience and neurostimulation education to you every week, free of charge. We're going to look at the latest research breakthroughs, how the technology works, and most importantly, how all of this is being translated into real-world treatments that can improve health and well-being. So whether you're a researcher, a clinician, a student, or just somebody who's curious about how our brains work and what we can do to help them to work better, this podcast is for you. My mission is to make the science accessible, inspiring, and relevant to your daily life. As part of my commitment to evidence-based analysis, in every episode that we discuss a specific study, I'm going to include an advanced critical appraisal of that study. If you're not interested in this deeper dive into the methodology and analysis, feel free to skip ahead on the timeline to focus in on other aspects of the discussion. This podcast is separate from my clinical and academic roles and is part of my personal effort to bring neuroscience education to the general public. Accordingly, I would like to emphasize that the information shared in this podcast is for educational purposes only and is not intended as medical advice or a substitute for professional medical guidance. Always consult with your healthcare provider to discuss your own specific health needs and treatment options. By listening to or watching this podcast, you acknowledge and agree that any decisions related to your healthcare are your own responsibility and should be made in consultation with a qualified medical professional. This episode is presented by ZipStim Neurostimulation. Full disclosure, ZipStim is the neurostimulation clinic that I own and operate. You can find out more about our clinical neurostimulation programs at zipstim.com. That's ZIPSTIM.com. Now let's get started. Today we're going to explore a groundbreaking study that could change how we view non-invasive brain stimulation for mental health. This episode focuses on a comprehensive review and meta-analysis titled Efficacy of Neurostimulation Across Mental Disorders, Systematic Review and Meta-Analysis of 208 Randomized Controlled Trials, published in the journal Molecular Psychiatry. We're spotlighting the largest meta-analysis to date on neurostimulation, covering an incredible 208 randomized controlled trials. This study provides a comprehensive look at two key techniques: transcranial magnetic stimulation, or TMS, and transcranial direct current stimulation, or tDCS. It evaluates their effectiveness across a range of mental health conditions, from depression and anxiety to schizophrenia and PTSD. So why does this matter? As mental health challenges continue to rise globally, especially in the wake of the COVID-19 pandemic, there's an urgent need for safe, effective, and accessible treatments. Neurostimulation is emerging as a powerful tool, offering hope where traditional therapies might fall short or are poorly tolerated. But what do the numbers say? Which conditions show the most promise? And how do we navigate the challenges of translating this research into real-world practice? In this episode, we'll break down the findings of this monumental study, and we're going to explore the mental health conditions where neurostimulation has shown the greatest potential. So grab a cup of coffee or your favorite beverage and let's get started. By the end of the episode, you'll have a clearer understanding of how neurostimulation fits into the broader landscape of mental health care and where it's headed next. Let's start by setting the stage. The study that we're discussing today is a meta-analysis, which is essentially a way to synthesize data from multiple high-quality studies. It provides a bird's-eye view of how effective neurostimulation really is for various mental health conditions. Now, what makes this particular meta-analysis stand out is its scope. It includes 208 randomized controlled trials, making it the largest synthesis of its kind for transcranial magnetic stimulation, or TMS, and transcranial direct current stimulation, or tDCS. So, what exactly are TMS and tDCS? If you're new to the podcast, here's a quick refresher. TMS uses magnetic fields to induce electrical currents in targeted brain regions, altering neural activity. It's most commonly delivered as repetitive TMS, or RTMS, and can be either high-frequency or low-frequency stimulation. tDCS, on the other hand, uses low electrical currents delivered through electrodes on the scalp. It doesn't induce neuronal firing directly, but modulates brain activity, making the neurons more or less likely to fire, depending on the polarity of the current. This meta-analysis doesn't just look at one condition, it spans multiple disorders, including depression, which is by far the most studied, generalized anxiety disorder, or GAD, obsessive-compulsive disorder, or OCD, post-traumatic stress disorder, or PTSD, schizophrenia, focusing on both positive and negative symptoms, substance use disorders, and even cognitive deficits like attention and working memory issues in disorders like schizophrenia. So what did they measure? Outcomes included reductions in core symptoms like depression or anxiety severity, and improvements in cognitive functions such as attention, working memory, and executive functioning. This broad approach provides us with valuable insights into where neurostimulation excels and where it might need refinement. Here is Yorick, my trusty brain model, who's here to help us visualize the key areas that are targeted by TMS and tDCS.
Alas, poor Yorick. I knew him, Horatio. A fellow of infinite jest, of most excellent fancy.
First, let's talk about the dorsolateral prefrontal cortex, or DLPFC. This is located just behind the forehead on either side of the brain. The left DLPFC is a common target for TMS in treating depression. High-frequency stimulation here is thought to enhance activity in underactive networks associated with positive emotions and motivation. The right DLPFC, on the other hand, is often targeted in conditions like anxiety disorders and PTSD, where low-frequency stimulation can reduce hyperactivity that's linked to fear and excessive worry. The DLPFC is kind of like the brain's executive assistant, helping us with decision-making, problem-solving, organizing our day, and regulating our emotions. Now let's consider the supplementary motor area, or SMA. This is located here along the midline of the brain. This region plays a crucial role in planning and coordinating movements, but it's also implicated in disorders like obsessive-compulsive disorder, or OCD. Low-frequency TMS at the SMA region can help to regulate repetitive behaviors by modulating overactive circuits. The parietal cortex, located here in this gray or purplish area, is another target for anxiety and attention-related conditions. By modulating activity in this region, tDCS can enhance attention and working memory, particularly in conditions like schizophrenia. This area helps us to process sensory information and focus in on what's most relevant in our environment. The concept of salience is important here and a key issue in terms of the cognitive symptoms of schizophrenia. In schizophrenia, the auditory cortex in the temporal lobes here in yellow is also a key focus. TMS here is used to reduce auditory hallucinations by disrupting abnormal activity in overactive circuits. What about the anterior cingulate cortex? Well, if we look here at what we call a mid-sagittal view, we can see the anterior cingulate cortex, which is involved in emotional regulation and decision-making. It's a secondary target in depression and anxiety where stimulation may improve emotional resilience. If we think about the connections, we can consider what's fascinating about them in terms of how these regions all work together. For example, the DLPFC is tightly connected to deeper structures like the amygdala. Here you can see the corpus callosum, which is the large tract of so-called white matter that connects the two hemispheres. You can't really see much more of the white matter on this model, but the white matter is basically the kind of like the wiring of the neurons that connects all of the different cortical regions together. And for example, the DLPFC is tightly connected to deeper structures in the brain like the amygdala, which processes fear, and the hippocampus, which manages memory. Again, you can't really see these deeper structures in this model, but the hippocampus would kind of be tucked in here in the what we call medial part of the temporal lobe, which is kind of, if you could open up that area there and look inside the kind of inner part of the temporal lobe, you would find the hippocampus, which is a critical brain region for managing memory. So by stimulating the DLPFC, we're not just affecting a single area of the brain, we're actually influencing entire networks of brain activity. If you have any questions about how these brain regions work or how neurostimulation affects them, feel free to drop them in the comments below. And don't forget, Yorick and I are both here to make brain anatomy as exciting and accessible as possible. Let's break down the findings of this study. The results of this meta-analysis are both exciting and nuanced. Let's go through them condition by condition, highlighting where neurostimulation shows the most promise. First, let's look at generalized anxiety disorder, or GAD. TMS was a clear standout here with a large effect size, or SMD of -1.8. Only 3 RCTs were included, but all used different stimulation protocols, including both high-frequency and low-frequency stimulation of the right dorsolateral prefrontal cortex, or DLPFC, and parietal cortex. This consistency across protocols suggests a strong potential for TMS in treating GAD, although more research is needed to refine the best parameters. Second is substance use disorder, or SUD. tDCS showed a medium to large effect size, an SMD of -0.73 for reducing cravings and symptoms related to substance use. No significant heterogeneity was found, which means that these results were fairly consistent. This is exciting because SUD, substance use disorder, is notoriously difficult to treat, and tDCS could provide a new, non-invasive option for helping patients. Third is obsessive-compulsive disorder, or OCD. TMS demonstrated a medium effect size, or SMD, around -0.66, with specific protocols showing even stronger results. The bilateral DLPFC stimulation stood out as particularly effective, with low heterogeneity. Low-frequency stimulation of the supplementary motor area, or SMA, and also right DLPFC also showed promise. These findings highlight the importance of tailoring TMS protocols to specific brain regions and symptom profiles. What about unipolar depression, or major depressive disorder? TMS and tDCS were both effective. High-frequency stimulation of the left DLPFC, a commonly used protocol, had a medium effect size. Bilateral stimulation showed a smaller but more consistent effect, with less heterogeneity. This reinforces the idea that TMS can be a game changer for patients with treatment-resistant depression, but protocol optimization is key. Fifth is schizophrenia. TMS and tDCS were effective for negative symptoms with medium effect sizes, but results for positive symptoms were less clear. tDCS was particularly promising for improving attention and working memory, addressing cognitive deficits that medications often fail to treat. This is a significant step forward, as cognitive symptoms are a major barrier to functional recovery in schizophrenia. Sixth is post-traumatic stress disorder, or PTSD. TMS demonstrated a large effect size with an SMD of -1.09, especially with low-frequency stimulation of the right DLPFC. This aligns with growing evidence that targeting specific brain regions can effectively alleviate PTSD symptoms, including hyperarousal and intrusive thoughts. Across these findings, what's clear is that both TMS and tDCS hold incredible potential for treating mental health conditions that are often resistant to traditional therapies. But it's not just about whether these techniques work, it's also about fine-tuning the protocols to maximize their effectiveness and ensure consistent results. Now that we've unpacked the findings of this study, let's explore what they mean for clinical practice and patient care. Neurostimulation techniques like TMS and tDCS are not just promising, they're already reshaping how we approach some of the most challenging mental health conditions. First, let's look at standardizing protocols for effectiveness. One of the most striking takeaways from this meta-analysis is the importance of session frequency and protocol standardization. For example, the analysis suggests that 10 to 20 sessions of TMS are optimal across conditions like depression, PTSD, and OCD. Interestingly, extending beyond 20 sessions doesn't appear to necessarily lead to greater benefits. What about treatment-resistant cases? Conditions like unipolar depression or major depressive disorder, PTSD, and negative symptoms in schizophrenia are notoriously difficult to treat with traditional pharmacotherapy and/or psychotherapy. Neurostimulation offers a viable alternative or complement to these other therapies, giving clinicians more tools to help their patients. For example, transcranial magnetic stimulation can help patients who haven't responded to multiple antidepressant trials, reinforcing its role as a frontline treatment for treatment-resistant depression. What about cognitive deficits? Cognitive symptoms, especially in conditions like schizophrenia, are often under-addressed by conventional treatments. These findings suggest that tDCS can improve attention and working memory, which could significantly enhance functional outcomes for patients. These kinds of improvements can translate into better everyday functioning, such as improved job performance or general ability to manage daily tasks. What about combining treatments for a synergistic effect? The study focused on neurostimulation as a standalone therapy, but previous research indicates that combining it with other interventions can amplify its effects. For instance, TMS plus cognitive behavioral therapy, or CBT, particularly promising for anxiety and PTSD. tDCS plus cognitive training, a potential game changer for ADHD and cognitive deficits in other disorders. These approaches suggest that future protocols might pair neurostimulation with existing therapies for a more holistic approach. How about expanding accessibility? One exciting aspect of tDCS is its potential for home-based treatment, particularly for conditions like substance use disorders and depression. This could make neurostimulation more accessible, especially for individuals who face barriers to in-clinic treatment. There's also the potential for app-based monitoring or remote supervision to help ensure safety and improve efficacy. Ultimately, the findings of this study remind us that neurostimulation isn't just about treating symptoms, it's about restoring function, hope, and agency to patients who may have felt left behind by other treatment options. While the results of this meta-analysis are promising, they're also a reminder that the journey of advancing neurostimulation is far from over. Let's discuss the key challenges and where we go from here. First, there are still significant research gaps. For example, conditions like ADHD and tic disorders remain underexplored with too few studies to draw firm conclusions. We also need more RCTs exploring long-term effects and how well benefits are sustained over time. Ongoing research is going to be very important to address these gaps in our knowledge. What about managing heterogeneity? One of this study's major limitations was heterogeneity, or variability in results across trials. Factors like stimulation site, frequency, intensity, and patient demographics all influence outcomes. For instance, high-frequency TMS on the left DLPFC shows promise for treating depression, but results vary widely depending on the number of sessions and patient characteristics. Future research must identify the best parameters for each condition, tailoring treatments to maximize efficacy. How about ethical and practical considerations? Accessibility and affordability are crucial. While tDCS offers potential for home-based treatment, ensuring proper supervision and preventing misuse is going to be critical. Similarly, TMS's cost and reliance on specialized equipment can limit its reach. There is a need for policies and programs to help make neurostimulation more affordable and available to underserved populations. What are some innovations on the horizon? Emerging technologies like closed-loop neurostimulation, which adapts stimulation in real time based on brain activity, could dramatically improve precision and outcomes. We need to explore the potential for AI-driven personalization, where machine learning algorithms help to identify the best protocols for individual patients. What about combining modalities for greater impact? We've discussed combining neurostimulation with CBT or cognitive training approaches, but what about pairing TMS with tDCS? Could these two techniques work synergistically to address both symptoms and underlying brain dysfunction? This might be an exciting area for future exploration. The future of neurostimulation is bright, but it requires collaboration across research, clinical practice, and policy in order to fully unlock its potential. Now, I'd love to hear from you. What are your thoughts on these challenges and opportunities? Reach out to share your perspective or suggest topics for future podcast episodes. Now I'm going to offer an advanced evidence-based critical analysis of this study using the PRISMA analysis. PRISMA stands for the Preferred Reporting Items for Systematic Reviews and Meta-Analyses, is a checklist and a framework that allows us to highlight both the study's strengths and potential areas for improvement. First, let's look at the title and the abstract. What about the strengths? The study's title clearly conveys its purpose: a systematic review and meta-analysis of neurostimulation techniques, TMS and tDCS, across mental health disorders. The abstract effectively summarizes the key findings, objectives, and methods, providing a comprehensive snapshot for readers. What are some areas for improvement? Well, the abstract could provide more detailed information on limitations, such as heterogeneity or publication bias, to give a balanced view up front. Second, let's look at the introduction. What were the strengths? The introduction establishes a strong rationale for the study by highlighting gaps in neurostimulation research and the need for comprehensive synthesis. The objectives are clearly stated, aligning with PRISMA guidelines to ensure transparency. What are some areas for improvement? It could elaborate on how this study builds on previous meta-analyses or systematic reviews, differentiating its contribution to the field in general. Third, let's look at the methods. What were the strengths? The study adheres to PRISMA's emphasis on a detailed methodology. It specifies inclusion and exclusion criteria, search strategies across databases, and the statistical methods used for meta-analysis. The use of randomized controlled trials, or RCTs, ensures high-quality data, minimizing the potential for bias. While the study includes 208 RCTs, it doesn't clarify how gray literature, such as unpublished studies or non-English studies, were handled, which may introduce some publication bias. The heterogeneity of the protocols, for example, variation in stimulation sites, frequencies, and session counts, is acknowledged, but not fully addressed in terms of its potential impact on pooled effect sizes. Fourth are results. What were the strengths? Well, the results were well organized with clear subgroup analyses for specific disorders like GAD, OCD, and depression. The effect sizes, or SMDs, are reported with confidence intervals, which helps in assessing the precision and reliability of findings. What about the limitations in reporting? High heterogeneity, or I-squared values, is reported for some outcomes, but not consistently explained. The PRISMA guidelines recommend sensitivity analyses, or meta-regression, in order to address heterogeneity, which could strengthen the findings. There's no discussion of small study effects or potential biases in specific subgroups, such as studies with high versus low risk of bias. Fifth is a discussion. What were the strengths? Well, the discussion contextualized the findings within existing literature, highlighting where neurostimulation has strong evidence and where gaps remain. The clinical implications are thoughtfully explored, including the importance of protocol standardization and the potential for home-based tDCS. What would be some areas for improvement? Well, the study does not sufficiently address limitations such as the reliance on studies with small sample sizes, short follow-up durations, or lack of blinding in some trials. The discussion could also include a more robust critique of the variability in effect sizes, particularly for conditions like depression, where multiple protocols are in use. Then there's the risk of bias assessment. What were the strengths? Well, the study included a risk of bias assessment for included RCTs, which is a key PRISMA requirement. Use of standardization tools, for example, the Cochrane Risk of Bias tool, ensures credibility. But what about the limitations? While the assessment identifies high-risk studies, it doesn't adequately explore how these studies may have influenced the meta-analysis results. Exclusion or subgroup analyses for high-risk studies could have added clarity. Limitations and future directions. What were the strengths? The authors acknowledge heterogeneity and the need for more targeted studies in underrepresented conditions like ADHD and tic disorders. Calls for standardizing protocols, for example, session count, stimulation parameters, are valuable for advancing the field. What could be some areas for improvement? Well, the study could expand on the ethical and practical barriers to implementing neurostimulation more widely, such as cost, accessibility, and patient adherence. There could have been a greater emphasis on the need for large-scale multi-center trials with longer-term follow-up, which could help to guide future research. Let's look at the overall quality and contribution. What were the strengths? This study is a landmark synthesis offering the most comprehensive evidence to date on TMS and tDCS across mental health conditions. Its findings provide actionable insights for clinicians and researchers, reinforcing neurostimulation's role in treating treatment-resistant conditions and in offering patients an alternative to traditional treatment options. As a final critique, this study excels in scope and rigor, but it could benefit from a deeper analysis of variability and publication bias, as well as more practical recommendations for integrating the findings into clinical practice. Using the PRISMA framework to critique this study highlights its strength as a comprehensive meta-analysis, while pointing out areas where future reviews and research could improve. By addressing these limitations, the field of clinical neurostimulation can advance even further, offering more precise, effective, and accessible care options for mental health. Okay, let's quickly recap the highlights of what we've covered. Let's summarize the key takeaways from today's discussion. We started by exploring the largest meta-analysis to date, which evaluated 208 randomized controlled trials on TMS and tDCS across various conditions. We learned that TMS shows strong potential for treating conditions like GAD, OCD, PTSD, and major depressive disorder, while tDCS excels in addressing cognitive deficits in schizophrenia and symptoms of substance use disorder. We discussed how tailoring protocols like focusing on specific stimulation sites or standardizing session counts can optimize outcomes for patients. And finally, we tackled the challenges, including research gaps, heterogeneity in results, and the need for greater accessibility and affordability in neurostimulation treatment options. These findings aren't just numbers, they're a testament to how far we've come in understanding and harnessing the power of neurostimulation in helping the brain to heal. Neurostimulation represents a frontier in mental health care, but it's also a field where there's so much more to discover. Every study, every clinical trial, and every patient experience adds another piece to the puzzle. Did today's discussion spark your curiosity? Maybe you're a clinician thinking about incorporating neurostimulation into your own practice, or maybe you're a researcher interested in the next big questions. I would love to hear your thoughts. Share them with me on our social media outlets or through the podcast's website on the comment section below, any way that works best for you. If you're a researcher or a clinician, consider joining the movement to push neurostimulation forward. Collaborate on studies, refine protocols, or explore how these techniques can complement traditional therapy options. And don't forget to tune in next time, where we're going to be looking in a fascinating direction that could redefine how we approach personalized mental health care. For more resources, insights, or to catch up on previous episodes, please visit our website or follow us on social media. If you've enjoyed today's episode, don't forget to like and subscribe, and also feel free to leave a review. It really helps us to reach more people who are passionate about mental health innovation, neuroscience, and neurostimulation. Thank you so much for joining me today on the Neurostimulation Podcast. I sincerely appreciate your time, your interest, and your attention. Until next time, stay curious, stay compassionate, and let's keep exploring the future of mental health care together.